Okay, let's move on here. So question, which of the following findings is most likely in a child with acute pericardial tamponade? A large V wave on the CVP tracing with severe TR on echo. B, a large A wave on the CVP tracing, so so-called Cannon A wave. C, an absent Y descent on the CVP and diastolic right atrial collapse on the echo. D, bulging in the intraventricular septum towards the left ventricle. And E, absence of the A wave on the CVP. Okay, and the correct answer there is C. So absent Y descent and then the collapse of the RA on the echo. So this is really meant to get at use of CVP and echo in terms of picking up things, hemodynamic variables on a patient. So absent Y descent, basically the Y descent, as I'm going to show you the CVP in a second, is the descent that's occurring after the ventricle contracts, leading up into the atrial contraction. And so basically if you have equalization of pressures between your RA and RV because they're being externally collapsed, you don't get that descent, okay? And so that's the reason why tamponade gives you that. The collapsing RA, that's the early sign of tamponade on an echo. The late sign is actually the RV collapses, right? And so those are things that are going to give you a tip off that you're dealing with pericardial tamponade. All the other things here were indicative of something, but just not tamponade, right? So large V waves indicate a V valve regurgitation. In this case, you're seeing TR on the echo. Cannon A waves tell you that you have something like complete heart block causing AV dysynchrony or just really high RV pressures like pulmonary hypertension. D is consistent with RV failure, so that's what a bulging septum looks like. And E, the absence of an A wave just tells you that the atrium is not contracting, right? So you have something like atrial fibrillation or some kind of supraventricular arrhythmia that's preventing contraction. So this is a look at our CVP tracing, and I think this is one of those things that, it can be very useful in the PICU, particularly in the Peds cardiac ICU, admittedly, but even in the regular PICU, because it can allow you to figure out some things quickly. And I think the place where I use it most is when there's a question about, is the patient in jet? Are they in AFib? Are they having an atrial arrhythmia? If I have a CVP, I can very quickly see whether there's an A and a V waveform, right? And a lot of times, some of these other subtle things, so the A, C, V, you may not get a tracing that's quite so good that you can discern the C wave. Often the A and the C seem to merge together and just go to the V, but it's very easy to see the difference between having an AV versus having just a V wave, right? And so obviously if you only have an A wave, that's a problem, right? That means no ventricle. But in the loss of atrial contraction, such as what's happening in jet or what's happening in AFib, you're just going to have a single waveform. And so if you have the CVP, very quickly you can look, because these tend to be tachycardic rhythms, right? And so the P wave is a lot of times going to be buried inside of the next QRS. And so a lot of times you're not going to be able to pick off the P wave, but you will be able to spot it on the waveform. And here I've given you a list of some of the different findings that you can see with CVP. So this is just a list that I would go over. I'm not going to read it for you, but it's good to be aware that all of these things are classic CVP findings with particular diagnoses, and these are very testable, so it's not a bad list to know for yourself. Okay, next question. A 7-year-old boy in septic shock is sedated and paralyzed with a pulmonary artery catheter in place. His CVP is 8, his pulmonary artery pressure is 36/20 with a mean of 25. Pulmonary artery occlusion pressure is 15. The vital signs include a pulse of 121, blood pressure of 115/56, temperature of 39.6. His mixed venous oxygen saturation is 64% with a hemoglobin of 7.6. His output by thermodilution is 3.5. The PVR in this patient, the pulmonary vascular resistance in Wood units, is, and there's a few options, 2.9, 3.4, 2.2, 5.4, 1.5. Okay, so the correct answer is 2.9, and I think that the importance here is just recognizing how the PVR was calculated, right? So I have the formula here for you, okay? So PVR in wood units I find to be much easier to work with than looking at dyne seconds. But essentially what you're gonna do is take your mean PA pressure and subtract the pulmonary occlusion pressure and then divide by the cardiac output, okay? So going back here, there's a lot of data you didn't need, right? The data that you needed was 25 minus 15, which is 10, okay? Divided by the cardiac output, which was 3.5. Okay, so in your head, you can already tell that that's going to be approximately, 10 divided by 3.5 is about 3. Okay, so 2.9 is going to be the right answer. Wood units is one way of calculating cardiac output. The other way, like I said, is dyne seconds, and there's a correction factor. This isn't something that I think you're going to need to do. I think it's more just being able to be aware of how the calculation is made. And really for PVR or SVR, the best way to think of it so you don't have to try to memorize a formula is you're looking at the pressure on the arterial end minus the venous end, or if you want to think of it, the ventricular end minus the atrial end, okay? So the mean pulmonary pressure is kind of the RV pressure, so to speak, okay? Minus the pulmonary occlusion pressure, that's kind of the left atrium, right? So now you're subtracting out what's at the tail end of the pulmonary circulation. And then the flow through the system is a cardiac output. So you're basically taking pressure divided by flow, and if you remember from Ohm's law, that pressure divided by flow then gives you resistance, right? On the systemic side of things, this, instead of being mean pulmonary pressure, would be just mean arterial pressure, right? And then you would, instead of using the PA occlusion pressure, which is LA, you would just use the CVP, right? Which is your RA, right? So mean arterial pressure minus right atrial pressure, again, divided by cardiac output, because cardiac output's the same, on both sides, is going to, well, assuming you don't have any shunts, sorry, but in most people, cardiac output's the same on both sides. And so in that situation, you're gonna get the SVR, right? So hopefully that makes it a little easier so you don't have to memorize things, okay? Let's talk then about pulmonary artery catheters in general. We don't use them a lot on pediatrics. It's generally adolescents, just because the sizes are, the smallest ones really, you got to be about 4 or 5 years old to get a PA catheter in. But they are used nonetheless, and they're very testable because of just how easy it is to ask questions about it. And the important part about floating a swan is just to be aware of what changes you're going to see within the pressure waveforms as you're advancing the catheter into the heart. So what this is here we are looking at the pressure at the distal tip of the pulmonary artery catheter as we're inserting it with the balloon inflated on the Swan-Ganz catheter. And initially we're in the SVC and then the RA. And the RA tracing and SVC tracing are virtually the same and look like this. And then all of a sudden we enter into the ventricle, and there's two ways of knowing that. The first one is all of a sudden the pressure shoots up, right? The other way is often this kind of tickles the heart and gives you a little ectopy. So that's another way to know you're in the ventricle. But if you see this big systole diastole, that's the right ventricle. And the way you know you've entered the pulmonary artery is that the diastolic side all of a sudden picks up, right? And so the systole really changes minimally, but the diastole all of a sudden picks up because the pulmonary artery obviously has kind of that slow compliance that allows the pressure to stay higher in diastole. And so once you're into the pulmonary artery and you have that higher diastolic, now you can kind of slowly advance further until you get to where it can't advance anymore, that the balloon has occluded the artery, and that is the pulmonary occlusive pressure, which also often we call the pulmonary capillary wedge pressure, although technically there's a slight difference between the two, but we often use those terms interchangeably. And notice that the wedge or pulmonary occlusive, artery occlusive pressure tracing looks a lot like the right atrial tracing, and the reason is because this is now an estimate of the left atrial tracing, right? Now there's a few important caveats here. One is that you have kind of a continuous column of blood running from your pulmonary artery to your left atrium, right? So if you have problems with anomalous pulmonary veins, or if you have an issue like a pulmonary embolism, that's not true, right? And so this becomes invalid. But assuming that you do have that, and then the other thing is you're in the right west zone, and we're gonna discuss what the west zones are, then you should get a nice tracing that looks like an atrial tracing. Often it'll be a lot lower pressure than the pulmonary artery, and that is going to give you an estimate of the left atrial pressure, and with it an estimate of the left ventricular end diastolic pressure, which is roughly proportional to the patient's fluid status / cardiac output. Okay, so that's how it's used, but this is literally the tracing you're looking at as you're inserting it within your patient. And where do you read the wedge pressure, right? So the wedge pressure is always read at end expiration, right? So what that means in a patient who's spontaneously breathing, expiration is actually going to take the pressure higher, because on inspiration they're sucking in, negative pressure. On someone on mechanical ventilation, it flips, right? But either way, you're going to read the pressure at the end of expiration. And also notice that you can have some effect of PEEP on this, okay? And that's because PEEP is just going to increase the intrathoracic pressure and change the relationship with the west zone. So I've talked about the west zones a couple times now, so let's actually look at them. And what we mean by west zones, so this is an example of somebody who's sitting up, and you know that when you're sitting up, the hydrostatic pressure within the pulmonary arteries and capillaries is a lot lower up high in the lung versus down low, right? And that's just because of gravity. So gravity is going to make it so that down low, the pressure of the blood, the hydrostatic pressure, is far higher than that of the arterial pressure, right? And in that situation, if you have a pulmonary artery catheter there, then this column of fluid reliably is going to be patent, and you're going to get a good tracing and a good wedge pressure. If you're somewhere in West Zone 2, depending on how the patient's breathing, their alveolar pressure may actually exceed their pulmonary capillary pressure, and so you may get some collapsing here in the middle. Okay, it's not going to exceed the arterial pressure, but it may exceed the venous and capillary. And so in that situation, this may not be so accurate, right? And certainly if you're up here, then your alveolar pressure may actually exceed even the pulmonary artery pressure, depending on what that is. And so in those situations, you're just not going to be able to rely on the tracing. Now, generally speaking, when we float these PA catheters, we go into the proper west zone. And I'm showing you on somebody sitting up, but when you're laying flat, you still have 3 west zones. It's just, the anterior chest, the middle chest, and the posterior chest. But if you start to see kind of erratic values or a waveform that doesn't make any sense, goes all the way down to 0, or shoots way up and then comes down dramatically, that could be because you've lodged into one of these zones. And so then the solution is to refloat the catheter. Cardiac output measurement can be done through 2 different means in cardiac output catheters, in pulmonary artery catheters. One is to do thermodilution. And so what we're doing with thermodilution is you actually inject fluid, and that fluid will generally be at room temperature. And obviously the blood is at 37. And so the blood is going to kind of, as that fluid gets incorporated into the blood, it's going to slowly warm the fluid up to body temperature. And depending on how fast the cardiac output is, that's going to be how quickly the temperature comes up, right? So in somebody who has really sluggish cardiac output, it's going to take a long time for that temperature to reequilibrate. In somebody who has really brisk cardiac output, they're going to get kind of a quick peak and trough, right? And so this is a fairly accurate way of determining cardiac output. It is susceptible to some problems if you have significant valvular regurgitation, because then the flow is not always forward, right? You may have some flow going backwards, and then it's just going to give you values that are, don't make a whole lot of sense. But if you have a nice tracing like this, and some of the software on the monitors will give you this, then you can rely on the cardiac output. Generally, we'll do this injection a few times before we accept it. A lot of the newer pulmonary artery catheters, certainly the ones that I use within our cardiac ICU all the time, actually have a thermistor. It kind of looks like a bronzish kind of tape around the distal portion of the pulmonary catheter, that thermistor actually heats up the blood directly and then rapidly cools down. And in doing so, it essentially is as if you're injecting warm fluid in, and it has the ability to then measure how quickly that warmed up blood hits the distal end, and based on that do a cardiac output calculation. And so that is the principle. So thermodilution is the principle behind the continuous cardiac output PA catheter using that thermistor. And because it's just not sporadically, but regularly warming and cooling down that thermistor, it's giving you continuous measurements of the cardiac output over time. Knowing the cardiac output, you already know the map almost always, because usually a patient who's sick enough to need a PA catheter is also going to have an A line. And because you have a PA catheter, you are directly measuring the CVP. So by definition, if you know these things, you can figure out their SVR, right? So the nice thing about having a PA catheter is, one, you can get a wedge pressure, which gives you an estimate of LV/EDP and gives you some idea about whether or not they are volume overloaded or not, or in significant shock based on their cardiac output. And then once you have that, you can figure out SVR and then decide whether they need to be on a pressor or just the opposite, on some afterload reduction. The second way of measuring cardiac output is the Fick equation. And the Fick equation is based on the calculation that basically cardiac output, so Q in this setting, is based on the arteriovenous difference in blood. And if you take the oxygen consumption, which is what VO2 is, and divide by that arteriovenous difference, you can get a calculation of the cardiac output. The Fick equation in some settings is more accurate, and in some settings is less accurate. So where it might be more accurate is if you have significant valvular regurgitation, then the Fick is going to give you a more accurate cardiac output than thermodilution will. On the other hand, if you have a patient who has significant anemia, where their arteriovenous extraction is increased because of that anemia, then the Fick equation is probably going to give you a number that's not so accurate, right? So it's just good to be aware of what drives these different measurements and how they're done to decide which one's the best one to follow. Often the correlation is quite good, which is what this is trying to show you here between the two. Okay. PVR we've talked about a few times, and generally the pulmonary vascular resistance is a lot lower than the SVR. So the ratio often is about 1:8, but in the case of pulmonary hypertension, that's going to go up to something around 1:4 or higher, right? And certainly if you are getting to half systemic or higher pulmonary hypertension, then it might actually clinically become significant and cause problems for your patient. The situations where we're going to see this is in the presence of mostly congenital heart disease, so things like ventricular septal defects, rarely ASDs, other kind of lesions that lead to a lot of flow, so anomalous veins and significant valvular regurgitation. And so in those situations, if you have a really high PVR, then it's important to note that, because that's going to really change the patient's prognosis and what therapies you can offer them. And the standard is essentially that if the PVR is greater than 3 Wood units, that's considered pulmonary hypertension in all settings, and some people would even go lower than that. But in those situations, you consider treatment with agents such as inhaled NO or Bosentan, and really, I think that's getting a little more into the cardiac physiology side of things. But from a monitoring perspective, the key here is you got to be able to measure it. And so a right heart cath, which is essentially the same as a pulmonary artery catheter, except frequently you're also measuring oxygen saturations, is the way that you're going to be able to make this diagnosis. Okay, so let's move on to the next question. You have a 4-month-old with SVT who's admitted to the PICU appearing dusky with prolonged capillary refill even after the termination of the SVT. You initiate an inotrope and would like to follow cardiac output non-invasively via echo. Which of the following is true? A, the shortening fraction by echo is unrelated to cardiac output. B, pulmonary systolic pressure can be estimated based on tricuspid regurgitant velocity. C, pulse pressure variation is rate dependent. D, mitral valve peak pressure gradient measures cardiac output. And E, diastolic dysfunction can be detected by using degree of aortic valve regurgitation. Okay, so here I made a bunch of statements that weren't true. The one that is that your pulmonary systolic pressure can be estimated using the tricuspid regurgitant velocity. What I'm getting at here is just that echo is able to be used to help you with monitoring in a few ways. Now, it's not as nice as, say, a PA catheter where you constantly have a number displayed on the screen, but certainly with the increasing use of ultrasound and presence of ultrasound within different ICUs, it's become pretty easy to do serial point of care echo, right? And so certainly, we use it within our units to get very quick estimates of, how's the function, how full is the ventricle, is there a pericardial effusion, how does the right heart pressure look, things like that. So in this answer, we're talking about the ability of echo to use the TR velocity to estimate RV systolic pressure. The equation there is 4V squared, where V is the velocity of the tricuspid regurgitant jet. And generally speaking, if the TR velocity is greater than 2.8, that's diagnostic of pH. And so the other ones are just all incorrect, but they're kind of hinting at other things that can be done by echo. So shortening and ejection fractions are roughly correlated to cardiac output, although they're very load dependent parameters, so you need to be careful about that. If a ventricle is underloaded, it's going to tend to look like the EF and shortening fraction are better than really the heart function is. In the case of cardiac output, the best measure is what's called the LVOT velocity time integral, and I'm going to touch on that a little bit later. Okay, so here's a picture of echo, and this is actually a nice three-dimensional picture, which is kind of cool to look at, but not clinically something that we use all that often. The more common that we use is kind of 2D echo, and so a couple things to kind of be aware of is that when it comes to performing your echo, how full or not full your heart is really going to impact how well it seems to squeeze or not, and how big the chambers appear. And so you do have to have some kind of gauge of what your volume status is, and recognize that an underfilled ventricle is definitely going to look like it's pumping better than maybe it really is. Doppler is something that we use all the time to look at things like valvular regurgitation, but it can also be used to look at things like the velocity of blood flowing through the valves, which will tell you things like whether you have diastolic dysfunction. So in diastolic dysfunction, the early blood flow, which should be higher than the atrial blood flow, starts to reverse, and the atrial kick contributes more of the blood flow within the diastolic cycle, and that's because you have a stiff ventricle, and so you need that push of the atrium to get more blood in. Now, there's some point where once a ventricle gets really, really stiff, flow kind of accelerates overall, and notice that this E and A, the velocities are high overall, and so this is what we call pseudo-normalization. So in that situation, you use other ways to measure diastolic dysfunction. Doppler is a great way to look at valves. It's a great way to look at the degree of stenosis across areas of narrowing. It's a great way to estimate regurgitation, and so we use it frequently for that. I think the equation 4V squared is a good one to keep in mind. It tells you the degree of systolic pressure within the right ventricle, but you can similarly use it with the mitral side to get some kind of estimate of what your systolic pressure is on the systemic side. Cardiac output is something that actually is better determined using what's called the velocity time integral. And again, I think these are equations you don't need to know. And so I'm not pushing them too hard for you, but it's more just be aware that echo has this ability and can do these things in terms of monitoring. The next type of monitoring I want to talk about is non-invasive cardiac output, and pulse contour analysis is one of the things that has really helped to revolutionize non-invasive cardiac output monitoring. For all these things, there are assumptions built in. And so there are inaccuracies with technology, but generally speaking, if you have a good, adequately dampened arterial waveform, so that's the first requirement. The initial part of the arterial waveform upstroke is an estimate of the cardiac output of the aortic. This part of it essentially looks like the aortic blood flow. And so the area under the curve of that is then what the cardiac output is. And so devices like the Lidco Express or the Pico, the FlowTrack, those are all systems that use this pulse contour analysis to calculate and give you a number of cardiac output based on arterial waveform. Now notice that there is this kind of patient-specific calibration factor in there, and that's important because on the devices, there are devices that can be calibrated, like the Pico, where you can actually do an injection and tell the machine, like, this is what the real number is. And there's devices like the FlowTrack that are not calibrated, and there, obviously, the non-calibrated ones are going to be off a little bit more. But all of these devices essentially will give you a cardiac output number, and often the trend on that number is the most reliable thing to look at. And so here I've listed just a series of devices that are commercially available, might be in your ICU. The USCOM is one that uses the velocity time integral from the suprasternal notch to kind of measure what cardiac output is. This is a picture of it right here. The CNAP or ClearSight was that finger one that I showed you earlier. This is a picture of it that recreates the arterial waveform from the finger and then analyzes it using pulse contour analysis. And then finally, the FlowTrack and Lidco Express are examples of straight up pulse contour analysis from the arterial waveform. So for these, you need an art line. For these, you don't need anything. So this is truly non-invasive, and this is what I would call minimally invasive, with full invasive being something like a PA catheter. So a few options to measure cardiac output, and depending on what your patient has, that may be important for management.